Yes, sir. We can hear you.
All right, great. Well, I want to welcome everyone to this month's Metropolitan Trauma Advisory Committee Multidisciplinary Conference period. Our speaker today is Dr. Sean Dieffenbaugher, speaking on alphabet soup of trauma patients in extremis. ERT versus REBOA. I'll let him explain that for us. Dr. Dieffenbaugher has come to us from his trauma and critical care and acute care surgical fellowship at the Medical University of South Carolina. And I can honestly say I'm surprised that his director there, Dr. Bruce Crooks, actually let him get away. It's been great to have Dr. Dieffenbaugher in our group. He did his fellowship again at the Medical University of South Carolina in Charleston. He did his surgical training at the University of Texas Health Science Center in Houston. Very happy to have him for our presentation today. Sean, take it away.
Thanks, Dr. Singh, and thanks, Scott, for the opportunity to present today. I appreciate you guys putting it at this time block because it coincides nicely with nap hour at our house for the kids. So if the kids get crazy in the background, that means they're awake at that point. So we'll deal with that as it comes, but thanks for the opportunity. Thanks for the wonderful introduction. No disclosures related to REBOA or resuscitative thoracotomy. List out the objectives here. So today we'll talk about some of the technical aspects and include some of the history of resuscitative thoracotomy. I'll talk about the definition and the variable number of letter combinations that can describe resuscitative thoracotomy. We'll review the current indications. We'll describe some patterns of survival, both historical and more current. And then we'll describe in some detail the use of REBOA, which is a catheter, which we'll talk about in detail for trauma patients. We'll briefly touch on some of the initial data and then some of the more current data for resuscitative thoracotomy versus REBOA and its applications. And then finally talk about the tools for salvage of our most severely injured patients. My goal is to leave about 10 minutes at the end, so this may seem like we're going fast through, but I want to leave some time at the end for discussion. So all good talks start with some historical perspective and some surgeons that have amazingly well sense of dressing there. So the first surgeon to discuss is Dominique Jean Leray, who was active in the 1700s and 1800s. He was a French naval surgeon under Napoleon. He's credited for describing the term flying ambulance, which was a team with a horse-drawn carriage, and they would evacuate battlefield casualties in the midst of battle. This triage concept was sort of the first concept described, where they actually treat the patients where they lay, they evacuate them with this flying ambulance, and they were treating all soldiers rather than what had previously happened is they would just treat officers and take them off the battlefield. He's credited with a story either of folklore or of truth, it's hard to know, but performed greater than 200 amputations in a 24-hour period during the Battle of Borodino in 1812. It's pertinent here because he's credited with the first pericardiocentesis for a penetrating cardiac wound. But it's worth noting, as a naval surgeon, he was forced into early retirement because he had intractable seasickness when he was on various ships. So as a Navy surgeon, seemed to be that would be one of the criteria for exclusion to be in the Navy, but nonetheless credited with the first pericardiocentesis. Christian Theodor Billroth goes by Theodor Billroth. He's a Prussian-born Austrian surgeon. He's credited as mostly the father of abdominal surgery. He was highly vocal and cautioned his colleagues as it pertained to operating on traumatic injuries and operating in the chest. He described it as the surgeon who should attempt to suture a wound of the heart would lose the respect of his colleagues, calling it the prostitution of the art of surgery and surgical frivolity. Many may have seen this picture before, but this is a painting from Adalbert Segelman from about 1890, but in the center is Billroth. The title of this painting was Theodor Billroth Operating. And so it's a common painting that we see around surgical units, but that's Billroth in the center. As we move into the actual penetrating wounds, from a historical perspective, Ludwig Renn was the first accredited surgeon for cardiac surgery for a traumatic injury. It was a 22-year-old kid stabbed in the chest while he was fencing. He first probed the wound, ultimately opened the right chest and repaired a 1.5 centimeter cardiac wound to the right ventricle. He subsequently presented his experience at a surgical conference, which incited widespread criticism that he would even consider operating on the patient. The first resuscitative thoracotomy is credited to Dr. Igelsrud, who was a Norwegian surgeon who was called in for a patient undergoing hysterectomy with subsequent cardiopulmonary arrest, in which he opened the chest, performed open cardiac massage with return of circulation in approximately a minute. The patient ultimately survived, and as he described in his details of the event, the patient was expelled from the hospital 5 weeks later. The last historical context to really discuss pertinent to the United States is Dr. L.L. Hill. This was in quiet Montgomery, Alabama in the early 1900s. A 13-year-old boy was stabbed in the left chest, was brought to Dr. Hill's house. He was barely conscious, but he was in shock, as he described it. He performed a thoracotomy on his kitchen table with chloroform anesthesia. He extended the pericardiotomy and again with catgut repaired the left ventricle. Subsequently published his case report in 1902, again widely inciting criticism for intervention for this injury. The last piece to talk about is Dr. Maddox, who published in 1994 a pre-hospital resuscitative thoracotomy, where the EMS crew had a physician riding with them. Ultimately, the patient arrested with a transport time that was concerning for 15 to 20 minutes, and the physician in the ambulance performed a thoracotomy. Subsequently, the patient survived his initial hospital course and survived to discharge. So it opened up the discussion points for the possibility of pre-hospital interventions. All right, let's move into resuscitative thoracotomy. So the disclaimer here is I have a lot of gruesome photos that are actual photos we've either taken or borrowed from other folks. But if you have a weak stomach and don't want to look at these pictures, the next 10 minutes will be fairly detailed in terms of photographs of resuscitative thoracotomy and its techniques. In terms of definition, again, from an alphabet soup standpoint, I think the most descriptive and most encompassing term is resuscitative thoracotomy. A lot of times these are called ED thoracotomies or emergency resuscitative thoracotomy. But really the technique is not limited by geography. It's not limited to being done in the emergency department. It can be done potentially in the pre-hospital phase, in the operating room, in the ICU, or in the emergency room. It's a rapid and dramatic and often heroic attempt at salvaging a critically ill patient. And so the next few minutes, mostly for our trainees, is going to be a kind of a detailed walking through of the actual techniques. I don't think we take enough time to stop and walk through each of the quick portions, the quick steps that we go through in terms of what we try to achieve, because often this happens very, very rapidly with not a whole lot of time to discuss what we're doing. It is certainly a procedure that has to be contemplated before you're able to successfully achieve the procedure. It needs mental modeling prior to performing, and so that you can think through the steps so that you can adequately, rapidly perform this technique in a safe manner. And that way it equips you with the skills to potentially salvage a patient. So from an equipment standpoint, the most important thing is knowing where it is. In our emergency department, it's readily available. But if you're in a smaller hospital or a more austere environment, sometimes it's the set of instruments that's up on the top shelf, covered in dust and hasn't been opened for a long time. So you don't know what's in there. But knowing where the equipment is and communicating with your team to have that available if you think you might proceed down that route. And therefore, it's open and inspected and ready to go. There have been a number of times where resuscitative thoracotomy is performed, but yet when they go to get the retractor out, the retractor is either put together inappropriately or has missing parts, and it quickly can bring what is a reasonable attempt to failure. What you really need out of the set are the four things here. So you need a scalpel, you need a pair of scissors, you need some sort of cross clamp, and you need a Finishetto retractor. The Finishetto has a long and storied history in and of itself, which was initially described and then subsequently improved by Finishetto, who was an Argentinian surgeon. So when you look at the whole kit, again, it comes with 30 to 40 instruments at times. And again, the last four things and these things are really all that you're going to potentially need. So a needle driver, forceps, Metzenbaum's, Satinsky clamp, the Finishetto, and a DeBakey aorta cross clamp. The Lebsky is important for when we convert this to a clamshell thoracotomy, which we'll talk about shortly. The major objectives when you're performing resuscitative thoracotomy is control of major hemorrhage, relief of tamponade if present, immediate repair of cardiac injuries as able, cross-clamping the descending thoracic aorta to decrease blood supply to the abdomen if that's the source of hemorrhage, open cardiac massage and internal defibrillation, as well as facilitating large volume resuscitation. So we'll go through all of these various things here. So from a technical standpoint, from an incision, the first thing is having somebody bring the arm out away from the chest. This opens up the rib spaces and facilitates better exposure and better ability to identify the rib spaces. The arm extended, again, opens that up. It's a curvilinear trajectory. It's not straight down to the bed, but it follows along the curve of the rib. And then it allows the use of scissors or a knife to sharply enter the pleural cavity. The inferior pulmonary ligament oftentimes limits how much you can retract the lung, and so sometimes that needs to be incised. The retractor itself can be placed and then opened sequentially, allowing a visualization. Interestingly enough, when you look at depictions of retractor placement, they consistently show it as a medial placement of the handle. I would argue that at all times you want to place this in actually 180 degrees from here so that the handle is on the bedside. So if you need to convert to a clamshell thoracotomy, you don't have the bar of the retractor in the way. But again, when you look in all the textbooks, it's typically depicted in this fashion. The clamshell conversion follows the line here. Again, if you suspect that there's right-sided pathology or you need access to the right side of the chest, it's a quick conversion by completing the thoracotomy incision across the right side, again in a curvilinear fashion to follow the trajectory of the rib, and then coming across the sternum with a Lebsky knife. The Lebsky knife is simply a blade with a strike plate and a malleable in the set as well. It's been well described in surgical residency that the number of hammer strikes it takes on the strike plate for you to get across the sternum is certainly a measure of your surgical fortitude. This is a picture of a clamshell conversion and a subsequent pneumonectomy patient. Again, this comes across and then retractor is placed with the handle towards the bedside to facilitate complete exposure to the thoracic cavity on both hemithoraces. All right, so from a technical standpoint, pericardiotomy is one of the initial steps if there is cardiac pathology. So the initial step requires you to identify the phrenic nerve running longitudinally along the heart and then opening longitudinally so that you don't transect the phrenic nerve. Oftentimes, if there is pathology there, there's a significant amount of hemopericardium, which allows you to open the pericardium either with a knife or with scissors, but without a significant hemopericardium, you do have to be careful not to cause additional cardiac injury when opening the pericardium. Again, this depicts that longitudinal pericardiotomy along the length of the nerve. And in real time here, just showing dissection, lifting the pericardium and showing you the neurovascular bundle. Aortic cross-clamping is one of the critical maneuvers of the procedure, which again is done with blunt or instrument dissection of the mediastinal pleura. If there's an OG or NG tube in place, you can feel that anteriorly, and therefore the posterior tube invested by the mediastinal pleura represents the aorta, particularly difficult when they don't have a pulse or don't have a blood pressure. So you're going for that posterior tube where you're developing a plane bluntly around the aorta. you're applying a clamp in the intervertebral space, and therefore hopefully avoiding injury to any of the perforating intercostal vessels and perforators. Atrial appendage cannulation is another technique that can be applied. So if you're struggling for access as a team, if you don't have a central line, if you don't have large bore peripheral IVs, and if you haven't put in an IO, I would presume that at this point, a lot of times that is done, but sometimes these patients come in with no access. And so simultaneously, somebody working on intraosseous access or intravenous access elsewhere. But if you open the chest, you can directly cannulate the right atrium. So that can be done in a number of ways. It can be done very simply with grabbing the atrial appendage, placing the luer lock portion of IV tubing within the right atrial appendage, and placing a clamp over the top of it, or a Ramel tourniquet on a purse string suture. Or we have described here on a number of cases cannulation of the right atrium with a cordis catheter, and then subsequently, again, purse stringing that in and suturing the line itself to the chest wall so that you don't have any migration. From a cardiac repair standpoint, obviously, as soon as you open the chest, if you suspect a cardiac repair, that's where you're going. The presentation of cardiac injury can be widely variable. Tamponade can be life-sustaining for the patient. It is important for our trainees to know that we all need to be aware of hemodynamic collapse on induction of anesthesia. So anybody with a significant pericardial effusion is preload dependent, and that preload dependence would dictate that if you give them induction meds or intubation meds, a lot of times that takes away the preload, and therefore you may have an arrest. So if you suspect tamponade, the idea is to intervene at the same time as induction and or endotracheal intubation. From a technical standpoint, these are suture plegited repairs in a horizontal fashion, typically done somewhere between 2.0 and 4.0, depending on surgeon preference. They're generous bites in most locations. The technical standpoint here, when it pertains to being near a coronary vessel, a lot of times you can pass it underneath and avoid ligating that vessel. It would be a shame to go through the whole process of suturing a traumatic cardiac injury and then subsequently ligating the LAD and having a massive myocardial infarction. If there's a laceration to the coronary vessel, certainly you want to include your cardiac surgeon colleagues, if able to consider revascularization attempts. One of the last steps, again, for internal defibrillation, I can't tell you how many times we've even discussed it, and they get out the paddles and people charge it to 200 and the whole team turns around and just yells out no, because the answer is charging to 10 to 20 joules, initially up to 50 joules. But again, that's for shockable rhythms of VTAC or VFib. You know, most commonly our traumatic arrests are PEA or asystole. And so while this isn't particularly common, sometimes we do have these patients after initial reperfusion. They may have issues with pulseless VTAC or VFib, which require internal defibrillation. Last consideration is obviously precautions. This is a dramatic and often dangerous procedure for the providers, and so full PPE is required. We know that the incidence of hepatitis and HIV is extremely high in our trauma population, and so depicted here is full PPE, which should be appropriate for all of these cases. So just to quickly run through the pearls from an equipment standpoint, again, a lot comes in the tray, but very little is actually needed. From an ET tube standpoint, you can manipulate the ET tube to help you, meaning if you're operating on the left chest, you can intentionally right main stem if you're limited by the lung. From an incision standpoint, again, a curvilinear incision at the 5th intercostal space, trending up along the rib allows adequate exposure. Clamshell extension typically allows you full visualization of the chest, and that's done with a Lipsky knife, understanding that the lima and the RIMA are both vessels that will need to be clamped, and then the maneuvers we discussed in detail. So to talk briefly about the indications, I'll give you some historical context. We'll talk about some of the current published guidelines from both the East and West organizations, talk about surgeons' preferences and adherence to the guidelines, and then ultimately we'll talk about how to move forward. So I'm not going to go through these in too great a detail, but you can't provide any algorithm without giving an overly complex slide that shows lots of arrows and lots of concerns, which you can't really interpret on the fly. And so the West organization provided this fairly simple discussion of our trauma patients and decision-making in a rather nuanced fashion for resuscitative thoracotomy. So for blunt trauma patients, their data would suggest that less than 10 minutes of pre-hospital CPR would be appropriate. For penetrating trauma patients, less than 15 minutes of pre-hospital CPR or less than 5 minutes of pre-hospital CPR in folks with penetrating trauma to the neck or extremity. The other indication would be patients in profound refractory shock despite massive resuscitation. And obviously, not to be outdone, the East guidelines subsequently a couple of years later came out with a significant working group of many names you guys will recognize there. Again, this was 72 studies they included in their review, 10,000 thoracotomies. All of it was based on describing the mechanism and then signs of life or without signs of life. And that's present on initial evaluation and present on evaluation in the emergency department. So again, you have a similar chart which demonstrates all of the various scenarios. So let's walk through these quickly here. So the only strong recommendation that they made was for pulseless penetrating thoracic injury with signs of life. They didn't necessarily define a time point, but again, we can we'll talk about that in our completion. The conditional recommendations were pulseless without signs of life after penetrating thoracic injury, pulseless with signs of life after non-thoracic penetrating injury, pulseless without signs of life after penetrating non-thoracic injury, and then pulseless with signs of life after blunt injury. The recommendation against was pulseless in the field without signs of life after blunt injury. And so while that may seem complicated, as we try to work through everything, it will help demonstrate when we do and we don't perform this. This was a Vanderbilt paper that came out, I think, in 2016 that discussed how surgeons interpret this information and what each surgeon's practice or the trends in surgeons' practice for when to perform resuscitative thoracotomy. Overall, there was 540 surveyed. 52% said they would do a thoracotomy for penetrating trauma with CPR of 5 to 10 minutes. 47% said they would do a thoracotomy for blunt trauma with arrest in the emergency department. Only 20% said they would never do a resuscitative thoracotomy for blunt arrest. So over the whole spectrum, even though we know that there's strong recommendations for resuscitative thoracotomy and penetrating injury with very short duration of CPR, there's wide variability in application of these national organization guidelines. Even further demonstrating it, the AORTA group reinforced that the practice is still widely variable, that resuscitative thoracotomy continued to be performed in blunt mechanisms without signs of life, up to about 14% of all included thoracotomies in this study. So again, not to get too deep into the details of each study, but it just shows that people didn't really understand how to interpret at times, or else they still were interpreting and performing the procedure. So sort of my thought is, how do we make sense of the guidelines? My typical approach is we want to know signs of life at the scene, meaning what were their vital signs at the scene? Were they interactive, or were they found down without any signs of life and CPR initiated immediately? And therefore, we have limited information about the duration of arrest prior to medical team's arrival. The presenting rhythm in the absence of pericardial tamponade by FAST. You want to also know what you think your likelihood of intrathoracic injury is. Obviously, we look quickly for bullet wounds and try to predict trajectory, understanding that thoraco-abdominal wounds may or may not present with a thoracic injury, but knowing that a thoracic penetrating injury increases your likelihood of having something to actually be able to intervene on in the chest. Anything with pulselessness greater than 15 minutes confers a very significant challenge to survivability. You also want to look at the overall trauma burden and injury severity score. And while you may not be calculating that, you can quickly assess if you think there are massive non-survivable injuries to the head and neck or the remainder of the torso. Age and risk factors and comorbidities certainly confer survivability. Young patients are able to tolerate more and tolerate prolonged periods of resuscitation. So when you put it all together, I think penetrating trauma arrest with less than 15 minutes. And in my practice, it's typically blunt trauma with arrest that's either witnessed just pre-hospital or in the trauma bay itself. And again, we know that survival with both of those is potentially limited. We studied, when I was at Houston, we published this paper. It's a multi-center review of 2 trauma centers in Houston, Baylor College of Medicine and UT Houston Memorial Hermann, just to evaluate what our overall thoracotomy volumes were, if our numbers followed along with what the general practice was, and if our survivability was similar. And so I'll skip the chart, but I'll tell you that this is important, a Kaplan-Meier curve of timelines. And so overall, in terms of timeline, the initial 24 hours is one of the most critical periods because they either survive or don't survive in that timeline. And then you see a small period of non-survivability following that. Overall, we reviewed 298 thoracotomies, 32% survived to the ICU. Overall, 9.4% survived to discharge. And so this is quickly the sum of the data there, which represents and fits with national data. But overall survival of resuscitative thoracotomy with arrest was penetrating volume of 11% and blunt volume of 6.8%. Again, that 24-hour timeline allows us to understand better how to discuss with families regarding a potential prognosis. Extended hospital course was about 40 days average length of stay and a high likelihood of complications, meaning each individual had an odds ratio of 2.4 for high risk of complications. However, those patients that did survive to discharge had functional, meaningful survival. And so a lot of times when we're reviewing some of these cases with resuscitative thoracotomy, we often ask, why did we even go that far? And I think some of the data, both this data and national data, would suggest that there is a survivability that's meaningful from this procedure. All right, to flip over to the next part of our alphabet soup is the REBOA. And so REBOA stands for Resuscitative Endovascular Balloon Occlusion of the Aorta. The REBOA has a storied past, initially with a very kind of clunky procedure that was done with a wire, with X-ray, took a long time. And subsequently, as technology developed and as industry partners joined in, we've gotten to be more and more facile with access and with placement of the catheter without the need for wires, without the need for fluoroscopy, and simply based on distance and knowing anatomy. The most important and rate limiting step, again, for our trainees here is vascular access. And so on the right, you see pictures of ultrasound. Understanding that the vein is medial to the artery, we are intending to cannulate the right common femoral artery or the left common femoral artery at all times. If you cannulate below, you can see in the bottom right, you have a superficial femoral artery and a deep femoral artery or profunda. If you put that catheter in the superficial femoral artery, it dramatically increases your risk of thromboembolic complications to the lower extremity. And so that diameter of the common femoral artery allows you to potentially decrease the risk of access site problems. Again, ultrasound guidance is preferred so that you can visualize and know that you're placing it in the common femoral. You can also utilize your ultrasound to visualize the inguinal ligament and therefore know that you're high enough but not too high and also not in the SFA. Those are critical steps in terms of placement. Obviously, when it comes to extremis, some of these patients are pulseless at this point. And so we'll talk about later the need for early access to help facilitate more success. But again, if you're placing this in a patient who is now pulseless, I typically proceed directly to open cannulation via a femoral cut down. And so across the bottom, you see it's just a longitudinal incision starting at the groin crease, overlying the artery. Quick dissection to identify the vein and artery, and then direct cannulation of the artery to allow placement of the catheter in a patient without a pulse. From an equipment and technique standpoint, we have a number of catheters and sheaths available to us for initial placement. Currently, we're using a 7 French sheath, which facilitates REBOA placement. Most commonly, we'll start with an 18 gauge A-line, which will allow arterial access and then subsequent upsizing of sheath if appropriate. This is the PREHOSPITAL catheter, which is one of the more commonly seen catheters. It's the one we currently use. There's a lot of smart techniques to this catheter, meaning it's got an arterial port that we can measure arterial pressure in front of the balloon. It's got a compliant balloon, length markers, and then a side port for us to allow both inflation of the balloon and then monitoring of that arterial pressure. You can subsequently transduce the sheath pressure as well so that you know the pressure below the balloon at the catheter site itself. The newer system that's available is the COBRA-OS system, which uses a lower profile sheath. That's a 4 French sheath. That may or may not portend decreased access site complications. Nonetheless, similar catheter overall with a compliant balloon, and then zone 1 and zone 3 markers on it. Again, as technology develops, I think our technology is directing itself to help manage some of the challenges, help facilitate easier access, and help to decrease overall complications related to access sites. This is a really important slide for everybody to understand who potentially could be placing a REBOA, but the zones of occlusion. So zone 1 is described as the descending aorta to the celiac axis. Zone 2 is the celiac to the renal artery. And zone 3 is infrarenal abdominal aorta to the aortic bifurcation. And so zone 1 is typically our placement, which is mid-thoracic aorta. That would be for any non-compressible truncal hemorrhage. So anything from a significant liver laceration or spleen laceration, anybody who's in extremis without an identified source, zone 1 placement would be appropriate. We avoid zone 2 because that zone includes all of the mesenteric vasculature. And so we try not to inflate the balloon in that zone to avoid injury to the ostia of those areas. Zone 3 is particularly pertinent for pelvic hemorrhage. We also utilize the REBOA in obstetrics, and so we typically proceed with a zone 3 REBOA placement to decrease hemorrhage associated with obstetric interventions. But again, in trauma, our most common application here is uncontrolled pelvic bleeding or a junctional penetrating injury, which can't be controlled with compression. And so zone 3, again, is a very short area, actually. It's infrarenal abdominal aorta to the bifurcation. And so that typically is a landing area somewhere between 7 and 10 centimeters. And so just to run through indications and contraindications. So in general, we describe our indications for the REBOA and trauma for refractory hemorrhagic shock from non-compressible truncal hemorrhage, both in penetrating and blunt abdominal trauma. The only contraindication, only absolute contraindication would be penetrating thoracic trauma or hemorrhagic shock secondary to a suspected thoracic injury. If you think about that, if you have an injury to the aorta or the heart and you place a catheter with a balloon in the mid-thoracic aorta, you're going to increase the pressure on that wound and therefore increase your hemorrhage. And so an absolute contraindication is suspicion of significant thoracic injury, which is the etiology of shock. It's important when you even consider REBOA that the REBOA serves as a bridge. It's a bridge to definitive operation or endovascular intervention. It's not something that's definitive in any way, but it helps to potentially allow you time to get to definitive intervention. And so you'll see that as we sort of compare here, that's a particularly pertinent understanding, that you understand your scenario, you understand your limitations, you understand what capacity your facility has, such that you need some definitive intervention shortly after placement. All right, so to kind of go through some of the comparisons of resuscitative and resuscitative thoracotomy and REBOA placement, this is one of the initial papers that started some of the discussion. So this is a 2014 paper from Dr. Moore and her group, including Dr. Holcomb, in patients with profound hemorrhagic shock. It was 72 resuscitative thoracotomies compared to 24 REBOAs, all with similar demographics, mechanisms, and injury severity scores. In the resuscitative thoracotomy group, the death in the ER was 62%, in the OR was 8%, and in the ICU was 19.4%. In the REBOA group, death in the ER was 16%, OR was 12%, and ICU was 33%. So while it was really just a feasibility evaluation, it kind of opened the floodgates for papers to consider what is our appropriate application and utilization of the REBOA. Clearly, this demonstrates that it's feasible, that there's improved survival in terms of timeline and fewer early deaths. Now, they didn't describe how meaningful the survival was in those particular patients that survived to ICU. However, it definitely demonstrates a prolonged timeline in terms of the opportunity to intervene on injuries, whereas in the resuscitative thoracotomy group, that opportunity wasn't afforded. Again, you can't talk about REBOA without talking about the aorta registry. And so, again, they compared REBOA versus resuscitative thoracotomy. And this group of patients was, as all indications for REBOA, was patients without penetrating thoracic injury, undergoing aortic occlusion, either at the descending thoracic aorta via thoracotomy or REBOA placement, all in the emergency department. The conclusion, again, shows that REBOA confers significant benefit in a patient that does not require CPR. However, in the arrested patient, they did not show any significant benefit. And so all of these sort of open the gates for more and more discussion. More contemporary literature, this recent publication from the Colorado group evaluated 97 REBOAs, 96% of them done in trauma, 65% overall survival reported. A couple of them were done for obstetric hemorrhage and surgical oncologic resections, but nonetheless 96% in trauma with 65% overall survival reported. They really describe more in detail the strategies to how to make a program work and how to understand what you need for a successful application and utilization of the REBOA, which requires some significant discussion of what the guidelines are, how to apply the technique, significant training for all of the residents, both in the emergency department and the surgical residents, providing that education on understanding the equipment, understanding the need for access, and allowing that to happen more rapidly. Dr. DeBose's group, a military group, subsequently described earlier access. And so we see a trend as more and more institutions are developing their REBOA protocols, that the initial evaluation of the trauma patient may begin with one individual directly assigned to right femoral artery cannulation with an 18-gauge arterial line. Typically, that is the most rate-limiting step. Once you get into the depths of extremis, it's very difficult to perform percutaneous cannulation when there's not a significant arterial pulse. And so a lot of these institutions who are heavy in the use of REBOA are starting the trauma evaluation, but at the same time, an individual is responsible for getting ultrasound access to the artery, placing an arterial line at that point, which then is available for immediate upsize. It truly just details, this paper, the importance of early access and avoiding some of the chaos that can come with the rate limiting step of cannulation. And so when you kind of try to put it all together, our pre-hospital expertise is one of the most important things that allows us to get these patients to treatment. And so from a pre-hospital focus standpoint, local control of hemorrhage is one of the most critically important steps. And so that's either through direct compression or tourniquet application. But again, in our junctional hemorrhage or our extremity hemorrhage, we see our teams doing exceptionally well with tourniquet application and immediate control of hemorrhage. Large bore venous access is critical so that when they arrive, we can rapidly facilitate massive transfusion. Facilitating rapid transport and avoiding delays if they're coming from an outside facility. Many times we'll see patients that come in with severe hemorrhage, but yet they have a CT scan from an outside hospital. And so facilitating that rapid transport, minimizing delays in terms of obtaining new imaging and getting them to treatment is critical. From a volume resuscitation standpoint, many of our pre-hospital vehicles are now starting to be stocked with blood products. And so balanced resuscitation with blood products or crystalloid resuscitation, if able, is critical to start that resuscitation phase. And then upon ER arrival, I think this is something we think about and talk about, but don't emphasize enough. If they're truly in extremis, rapid communication of the critical information allows quick change of information, but also not too much time that stops the progress and initial evaluation of the patient. Discussing the trauma surgeon's toolbox, I put over here a hammer and a wrench, and we'll come back to that in just a minute. But the toolbox for the surgeon, initially, again, access is the most critically important step, and that includes a large bore peripheral IV access, intraosseous access, or a central line above the level of the injury if possible. And again, many times if you have a patient that comes in without any access, the goal is to start all of those at the same time, and whoever gets one in first, for lack of a better term, wins. But again, rapidly establishing large bore access for massive resuscitation is important. From a massive transfusion standpoint, that depends on our large bore access, but also functioning rapid infuser, a team that is adept at getting blood products, getting them spiked, getting them run through the rapid infuser. And again, balanced transfusion with a 1-to-1-to-1 ratio of PRBCs to FFP to platelets and cryo as appropriate. We also discuss permissive hypotension at times, which in theory allows you not to pop the clot. And so we're shooting for a systolic blood pressure above 90 or a perfusing pressure without causing significant hypertension, which in theory could potentially pop the clot. As you see, our technological use around the extended fast or pericardial fast plus the abdominal fast allows us to have very quick information about the presence of a pericardial effusion and allows us to change the course of what our resuscitation might be based on that information. We can quickly look at bilateral chest with ultrasound to see lung sliding and increases our suspicion of a hemothorax or pneumothorax that may need intervention. At times our x-ray can be delayed and that EFAST allows us to get that information more quickly. But truly in extremis or peri-arrest, we will decompress both chests, and that's either done with finger thoracostomy or chest tube thoracostomy as a diagnostic and potentially therapeutic tool to give us an idea and understanding of what pathology lies in either chest cavity. And then as we step through the next few steps, I think timing is the most important consideration, and it's time to definitive intervention. But if they've progressed through and you've done massive transfusion, you've got your access, you've decompressed the chest, you've proved that there's no pericardial effusion, refractory hypotension or arrest, you've now got the decision of considering where to go next and what time it takes to get there. And so this is a really nuanced and highly criticized decision. A lot of times, when we're reviewing our cases, this is sort of that breakpoint of they were either hypotensive and can you proceed directly to the OR for intervention? Now, when I was on call the other night, I timed out that proceeding directly to the OR. It was approximately a minute and a half in the bay before we were ready once we had made the decision to leave. It's a minute and a half to the elevator and on the elevator. It's 2 minutes from the elevator around all the corners, avoiding all the things that are parked in the hallway and ultimately into the operating room. And then another 3 minutes from moving the patient over completing report, and then prepping and draping. And so while we like to say that the operating room is just a couple floors away, there also is a period of time there where we've got decreased monitoring, we've got decreased resources available, we've got decreased team members. And so that's one of the nuances of the decision of how to proceed, which is, do we think their blood pressure and their clinical status will allow them to survive an elevator ride 2 floors up and a walk around the hallway? But those techniques and those decision points are either proceeding directly to the operating room or these decisions of REBOA placement or resuscitative thoracotomy. Again, a lot of it is nuanced based on refractory hypotension, degree of hypotension, overall injury burden, age, comorbid conditions, what the suspicion of true underlying injury is. Again, in an immediate arrest patient in front of you with penetrating thoracic injury, I think most trauma surgeons would say that they would proceed directly to thoracotomy. However, in penetrating abdominal injury or blunt arrest, again, those bring up the idea that maybe there's an alternative to opening another cavity and having the morbidity of opening the chest cavity. Like I said, I wanted to leave about 10 minutes for discussion at the end. So in conclusion, you know, as we look at resuscitative thoracotomy, you could spend hours talking about the history and the changing practices. You can see that it's got a long and storied history. Being that it's such a dramatic and attempted heroic procedure, certainly there's a lot written, and it's very interesting to read some of these papers from the late 1800s and 1900s on the descriptions of interventions for traumatic arrest. From a technical standpoint, again, for our trainees, I think it's a procedure that you have to mentally model multiple times before you're able to master that and rapidly proceed with the procedure to achieve the objective you're trying to achieve. Understanding the guidelines, again, the West versus the East, and understanding penetrating versus blunt and signs of life versus no signs of life. Unquestionably, it's very muddy waters and at times a very nuanced decision of whether or not to proceed with resuscitative thoracotomy, and often a highly criticized decision, not just now, but not just 10 years ago, but historically the same. Our REBOA applications, again, I would say that the most important thing for everyone to consider is early application. If you intend to proceed with REBOA, early arterial cannulation, understanding that thoracic pathology is an absolute contraindication. Otherwise, you're balancing some of these decisions of REBOA versus resuscitative thoracotomy. And I would say, again, going back to the hammer and the wrench, they're not interchangeable. Sometimes they overlap in what you can do with them, but these are not interchangeable techniques and not applied in the same circumstances. And identifying who can benefit from a REBOA, who can benefit from a direct trip to the operating room, and who requires a resuscitative thoracotomy are some of the challenges. From a future direction standpoint, you know, the REBOA technology has been around and has been continuing to get better and better as we see new generations of catheters. You know, when the PREHOSPITAL catheter came out with a 7 French access site and no wire, everybody thought it was the next greatest invention. Now we see catheters that come out with, again, no wires, but even a smaller access site or sheath site with a 4 French. And so as we continue to partner with our industry partners, I wonder if it becomes routine or if it becomes part of what happens in the field. And I think there are some investigations ongoing regarding pre-hospital access, but I would say that many of the successful REBOA programs that detail survival rates of 65 or 70%, that centers on early access to the artery before the patient goes into any sort of arrest. With that, I will pause and take any questions. Thank you for your time and participation.
Well, that was a tremendous review. Thank you very much for that. Let's start with some questions from the audience. I have a couple questions myself, but I'll hold them to the end. Dr. Haney?
Hey, can you guys hear me?
Yes, very clear.
Okay, good. I'm on my home computer, so hard to tell. I was just curious. That was really a fabulous talk. I love the historical review, and I wasn't really aware of all of the controversy that existed before. So thank you for educating and updating us on that. I was curious about if you had any information on the cost of the REBOA. I think it was, I don't know, something around $10,000 when I was training in New Orleans. But it's something, we think about every once in a while. We'll get a patient over at Cleveland that, I think this would have been a good REBOA patient. And obviously, we don't have the systems in place or get enough patients to really be proficient in that systems level skills that you need to really be able to, I think, utilize this, procedure effectively. But I just didn't know if you had anything on the price point where REBOA is at these days.
Yeah, that's a great question. I think it's a moving target. There have been a couple of publications in the last few years that do describe survival of resuscitative thoracotomy versus REBOA, and it's about a 50% reduction in cost. The numbers necessarily aren't described, but overall they describe something like 21,000 versus 49,000, and the higher group being the resuscitative thoracotomy survivor. Now, the actual catheter cost certainly is not that high, but I think that is a moving target based on facilities and negotiating and all that sort of stuff. I think what you look at is, how do we apply this? How do we apply it effectively? And I completely agree. I think that every once in a while, placement here, it may be difficult to be effective with that. And so I think that's what requires high volume and constant repetition with many team members being familiar with the procedure itself. Because a lot of times what you'll see is by the time you need the catheter, at that point you don't have arterial access, and a lot of times that's gets you into a non-salvageable situation. So I think it's would be interesting for us to review what our catheter costs. I know we've reviewed our outcomes, and as I see a question in the chat there from Dr. Willis, which I can address while I'm on. No question that, we have, number one, I think understanding your outcomes is the most critically important first step. And I'm not sure we have a great handle. We've heard numbers before as, 1 in 40 survivors of REBOA, and I'm not sure how those are necessarily captured. But our survivability should be profoundly higher than that. And that should cause us or drive us to consider how we are employing this. Are we employing it too late? Are we getting access too late? Do we not have enough people familiar with the procedure such that it's not a smooth procedure? But certainly early access is important if you do plan to go down this route. And again, I think if this is reactive to arrest, the REBOA is a really challenging procedure to complete.
I see hand up by Dr. Lauer.
Hey, can you hear me?
Yes, very clear.
Okay, thank you. So I just have a question. I think with a resuscitative thoracotomy, that is a very intimidating procedure, and most people do not, most non-surgeons and even non-trauma surgeons, comfort to do that. And I think that with the advent of REBOA, this is kind of really opens the opportunity for non-surgeons to be more involved in aortic occlusion, and seemingly a simpler procedure. This has potential to be pushed farther forward, as you referenced, and certainly in the military setting, there's a lot of interest in pushing it far forward on the battlefield. But ultimately, the REBOA is still just a bridge to something else, and a bridge to definitive control, or hemorrhage control. And I just wondered what your thoughts were about, its use in a pre-hospital setting, and or in a center where there is not a surgeon available. Should this even be considered if you are not within less than an hour of getting to definitive source control.
Yeah, thanks, Dr. Lauer. You've nailed the commentary on REBOA use in the pre-hospital setting, and I think that exact time is a moving target, whether that's 30 minutes of occlusion or an hour of occlusion. Unquestionably, beyond an hour, if you don't have intervention, I don't think this is a viable technique. My suspicion would be is that you need to have immediate intervention, whether that's interventional radiology or operative intervention within 30 minutes would be my sort of description for timeline, because you got to think if you're mobilizing a surgeon and then or transferring, either one of those timelines is approximately 30 minutes, and so your ischemic complications from occlusion at that point probably preclude any meaningful survival. And so that number is not well described in the literature at this point. There are a number of pre-hospital investigations ongoing, and as you referenced, particularly in the military setting. But no question there has to be immediate or near immediate surgical and or endovascular support available, or else this is a useless bridge to nowhere.
I believe I saw Dr. May's hand up, but I think he dropped. Dr. May, are you still there? Okay, no. Well, if you can still hear me, I have two fairly straightforward questions. One, we're a very busy trauma center, and we don't have a huge experience with this procedure. And I guess my question is, are we not using it enough? What should we be more aggressive, and what population should we be using it that we haven't at this point in time? You know, one of the things about the REBOA in some of the earlier studies, particularly out of shock trauma in Maryland, when they were talking about their pelvic fracture management, was the fact that their average time to getting embolization was pushing 3 hours. We definitely have a rapid response from our interventional radiology team to actually being here inside of a 30-minute window, which is really tremendous. So I guess the question is it still worthwhile if we're moving relatively that much quicker with interventional radiology? But again, I think overall our utilization for our trauma volume is relatively small. And then sort of on the concept of the alphabet soup of in extremis, I'd be curious about your thoughts about the role of ACLS medications in the patient who is in extremis.
Excellent questions. Thank you, Dr. Singh. Again, I think, we're a relatively low utilizer of REBOA, and I think as you look at some of our cases, it's typically very reactive. And so that's in the peri-arrest phase as a salvage attempt. I think the centers that are more successful are describing early access so that it's available for quick upsizing. Again, the access is the rate limiting step, probably a less than 2 minute procedure if done effectively. And therefore that access is available and ready to be upsized immediately, which is quickly done over the wire. I think our potential opportunity for improvement, again, I think we've improved our time to interventional radiology numbers to the point where, to your comment, 3 hours is just unheard of for interventional radiology. And so if you have IR immediately available, then I think that it's not a potentially helpful intervention. But if you have some delay, or if you don't have any other intra-abdominal pathology and it's clearly pelvic, it is a good role for bridging to that intervention. But I think our opportunity for discussion and potentially improving our outcomes is earlier arterial access, again, with an 18 gauge or with a micropuncture sheath. That way you have it available for upsize and utilization. And I think that patient population is not the peri-arrest patient, but it's the profoundly hypotensive in an effort to decrease blood loss while you're initializing your resuscitation with MTP. To your second question, you have clearly capitalized on the opportunity for discussion of whether or not ACLS drugs are appropriate in trauma patients. It's made its way back into the textbooks in terms of administration of epinephrine. Certainly intracardiac epinephrine, I would say, probably provides a meaningless resumption of cardiac activity without significant survivability, but it's hard to predict because we're not able to necessarily study those. I would say that every time ACLS protocol is ongoing for a trauma patient, nearly every time I've been involved, epinephrine has been given. The decision not to give that is often one that's controversial and immediately initiates a lot of conversation in the trauma bay. And so I think certainly as a group, we need to discuss what our role for ACLS medications, particularly epinephrine in the arrested trauma patient.
Well, thank you, Dr. Dieffenbaugher. I don't see any other questions from the group.
There's 2 questions in the chat box, I believe.
Oh, fire away. I don't see them. Sean, can you see the chat box?
Hey, Sean, one of them, it's mine. It's Dr. Torres.
Yep.
Briefly mention in terms of time, if you have the data available, how long does it take placement of REBOA versus resuscitative thoracotomy?
Yeah, great question, Torres. I think there's published data that is difficult to interpret because, again, what you're talking about is arterial access, subsequent upsizing of sheath, and subsequent placement versus if you already have access, all you need to do is upsize your sheath and move forward. So the typical process for somebody who's very skilled with a patient that is not pulseless for access, upsize, and placement is about 3 minutes. If you look at videos from Dr. Dubose, he describes a lot of the technical complications and pitfalls. He's done it on the East Cast and a number of other ways to describe it. And he'll tell you that it can be done in 2 minutes approximately. And again, that's depends on skilled providers without issues in terms of having the box available and having all the components within the box. Similarly, when you do a resuscitative thoracotomy, if you have skilled providers, that can be done with aortic occlusion in somewhere between 3 to 6 minutes. That's multifactorial again, meaning having the equipment open and available and having a skilled provider to go immediately for the aorta. So while you try to interpret the data as REBOA is quicker or thoracotomy is quicker, there are so many factors related to the multidisciplinary team, related to the preparation, related to the skill of the individual that can dramatically alter those timelines. If you're going for a REBOA and you bend the wire or you kink your sheath or you access the vein the first time, it profoundly changes the timeline for your opportunity for intervention. And so again, I think, in an institution where we haven't done much education regarding REBOA, it may be an opportunity for us to bring the best course or the REBOA course or some component of it so that we have our residents and our faculty trained in terms of how quickly this can be done and how effectively it can be done. And again, focusing on early access of the artery. All right, Scott or Dr. Singh, are there any more questions you guys see?
I don't see anything else right now. Scott, do you see anything else in the chat?
I think
No, I don't think so.
Cunningham raised his hand.
I think there's one more question in the chat from Grant Willis. Do you want me to read it?
Sure.
Okay, Dr. Dieffenbaugher, thank you for an excellent review and talk on resuscitating the traumatic arrest extremis patient. Based on your current and past experiences at other trauma centers, do you have any thoughts on how we can improve our mortality rate for resuscitating the traumatic arrest patient at CMC?
That's an excellent question from Willis. I think, again, the best way to improve our mortality is to avoid arrest. And I think that's with early access, early massive transfusion, and early access for REBOA placement. And again, it's not meant for everybody, meaning for every patient, but certainly when you get to the point of arrest and you're either performing a thoracotomy or you have a REBOA inflated, when you get to the point of needing aortic occlusion for arrest, we know that survival nationally is somewhere between 5 and 12% for functional survival at discharge. I don't know what our numbers are here, but it's so multifactorial in terms of speed of procedure, volume of resuscitation, the interventions able to be performed. Part of that is evaluating on who we're doing a thoracotomy on. Are we doing them outside of indications? In the blunt arrest patient, are we doing those too far out of their window? Versus can we potentially avoid some of the arrested patients by resuscitation and providing a REBOA, performing a REBOA earlier on? And I think that's maybe the bridge to surgery there. So if you have significant non-compressible hemorrhage and you get the REBOA up on arrival instead of waiting till they arrest, maybe that confers increased survivability. So it's certainly multifactorial, but I think the one thing that can be affected is training of our individuals, becoming more facile with the procedure and moving to quicker arterial access in the right groin to have that option available in case you get there. But great question. Thank you.
And one final comment from Dr. Blackwell. He's the current EMS fellow with Mecklenburg EMS. He stated the problem with pre-hospital REBOA is getting the proceduralist to the field. Arterial cannulation is not something that paramedics can perform. In systems in which the resources are available to get a surgeon or an ED doc to the field, response times are generally in favor. In the more rural setting, you run into a lot of time restraints, as Dr. Dieffenbaugher suggested.
Yeah, that's a great comment. Again, time matters, and having intervention immediately available or immediately available is paramount for this. So you've got to focus on it as a bridge and not as a definitive intervention for sure. But again, if people don't start pushing the envelope, there won't be any progress here. And so I'd refer you back to the historical comments from Dr. Bill Roth, which would say that no one should ever sew on the heart. So if we stop there and listen to him, there wouldn't be much progress. Thanks, y'all.
I will listen. Thank you. And thank everyone in the audience for participating. And thanks for a great question and answer session. And I think you've given us a lot of thoughts to ponder, particularly before our next patient comes in, maybe tonight. Again, thank you very much.